There are two forms of strokes: ischemic strokes, which accounts for more than 80% of the cases of strokes, and hemorrhagic strokes, which accounts for less than 20% of the cases of strokes. So in a separate video, I have discussed the ischemic stroke as well as mini stroke, which is also known as transient ischemic attack, which lasts for less than 24 hours. Here I'm going to discuss the hemorrhagic stroke and also discuss the hematoma. And so hematoma is bleeding inside the skull, and so it's not really considered as a stroke, and that's why I've written it separate from the hemorrhagic stroke. So what I will do is that first I will start with the hematoma and then discuss the hemorrhagic stroke after that. So there are two forms of hematoma: epidural hematoma and subdural hematoma. And in order to understand what I mean by the terms epidural and subdural, first I would like to review some basic anatomy of the meningeal layers. So here on the top we have the bone from the skull, and at the bottom we have the brain. So in between are the meningeal layers, which are made of the pia, arachnoid, and dura. And if you have problem memorizing the order of these layers, just think of pad. So pia, arachnoid, and dura. So the meningeal layers provide a pad to the brain. Now the space between the arachnoid and pia is referred to as subarachnoid space. The space between the dura and arachnoid is referred to as subdural space, and then the space between the dura and bone is referred to as epidural space. So here I have an example of epidural hematoma, which is due to the fracture of a temporal bone that causes rupture of a middle meningeal artery, as a consequence of which the blood that is released will cause compression of the dura and the brain matter. And so this type of hematoma has a lens-shaped appearance. So here you can see how it has a lens-shaped appearance. On the other hand, subdural hematoma is from the rupture of the bridging veins that are going from the subarachnoid space into the dural space, and so therefore if the bridging veins are broken, they would release the venous blood inside the subdural space. So if you've noticed, for the epidural, I've shown the bleeding with red color because the source is the artery, versus the subdural hematoma, I've shown it with a blue color because the source of bleeding is from bridging veins. Now in any case, compared to the epidural hematoma, which had a lens-shaped appearance, subdural hematoma has more a crescent shape appearance. So you can see how it's wider compared to the epidural hematoma. And so epidural hematoma, actually, since the dura is tightly bound to bone, it won't be able to cross the suture line. But then with the subdural hematoma, it's under the dura, and so it would be able to cross the suture line. So that's one feature that is different between the two forms of hematoma. Now let's review important points about these forms of hematoma. So epidural hematoma is caused by fracture of a temporal bone. It results in rupture of a middle meningeal artery, as a consequence of which it will release blood in the epidural space. Now this type of hematoma does not cross the suture line, and again, as I explained, skull and dura are tightly attached to each other, and so therefore hematoma would not be able to cross the suture line. The appearance of this form of hematoma is lens-shaped, and then these patients will initially go unconscious, then they will regain consciousness. So this interval is referred to as lucid interval, when they regain consciousness, and then they would again become unconscious as the hematoma keeps on increasing in size. So therefore patients with epidural hematoma presents with a lucid interval, and then rarely they may present with cranial nerve 3 palsy due to the impingement of a cranial nerve 3. So the memory aid that I have for you is already embedded in epidural. So E stands for ellipse. So the type of hematoma has a lens-shaped or ellipse appearance, and then I, which can be also read as L right here, is for lucid intervals. So epidural hematoma presents with lucid intervals, after which the patient loses consciousness due to the enlargement of a hematoma. The next condition is subdural hematoma, which is from the rupture of bridging veins that usually happens from blunt trauma or a fall. And this condition is more commonly seen in elderly patients. Now, can you come up with a reason that why subdural hematoma is more commonly seen in elderly patients? So the reason is that brain atrophy is more common in elderly patients, which will provide room for the bridging veins to move and therefore rupture following a rapid movement or a fall. So therefore, due to the brain atrophy, elderly patients are at increased risk of subdural hematoma. And then we know that elderly people are also at increased risk of falls, so the two combined together, we see the subdural hematoma more commonly in elderly patients. Now, initially, these patients may be asymptomatic, but as the hematoma increases in size, they would present with progressive headache as well as an altered mental status. Now, the memory aid that I have for you is subway under the bridge. So subdural hematoma is caused by the rupture of a bridging veins. So subway under the bridge. Now here I have a CT image that will differentiate between the subdural and epidural hematoma for you. So here you can see on the right side we have hematoma that has a crescent shape of a hematoma. And so here, compared to the image here, it's kind of like wide and not lens shaped. Versus the image on the left, it has a lens shaped appearance. So therefore, these patients will have lucid intervals, while these patients on the right will have progressive headache and altered mental status. I mentioned earlier that cranial nerve 3 palsy is a rare complication that can arise from epidural hematoma. And so in order to understand why patients will present with the symptoms listed here, like ptosis, dilation, and the eye looking outward and down, you will have to know what cranial nerves innervate the movement of the eyes. So the 3 cranial nerves that innervate extraocular muscles are cranial nerve 3, cranial nerve 4, and cranial nerve 6. Now the memory aid that I have for you is called L6SO4. So it's like a chemical formula, like H2SO4. Forget about that and memorize this new one, L6SO4. So cranial nerve 6 innervate the lateral rectus. So lateral rectus for cranial nerve 6. And then cranial nerve 4 innervates superior oblique. So superior oblique, and every other extraocular muscle is now being innervated by cranial nerve 3. In addition, cranial nerve 3 is also innervating the levator palpebra superioris, which is required for elevating the eyelid, and then it also innervates the sphincter pupillae, which is required for the constriction of the eye. Now, what happens when there is a lesion of cranial nerve 3? The eyelid will keep on falling. So these patients will have a droopy eyelid or ptosis. And one way that I memorize that cranial nerve 3 is required for keeping the eyelid open is that I imagine an eye with 3 pillars holding it open. In addition, cranial nerve 3 is innervating the sphincter pupillae. So since the sphincter pupillae is no longer working, it will cause dilation or mydriasis of the pupil. And then finally, the extraocular muscles of cranial nerve 3 are not working. So what happens now is that cranial nerve 4 and 6 will take over. So what's the function of cranial nerve 6? To look laterally. So that's why the patient looks out. What's the function of cranial nerve 4? Here I'm going to provide you with another memory aid. So the function of cranial nerve 4 is solid. So superior oblique is required for lateral movement of the eye, intorsion of the eye, and depression of the eye. Now with that information in mind, since the cranial nerve is not working and superior oblique will take over, so there would be lateral and depression of the eye. So that's why that you see that this eye is now looking out and down. So therefore, that's the symptoms of cranial nerve 3 palsy: ptosis, dilation, and outward and downward movement of the eye. The next condition is intraparenchymal, also known as intracerebral hemorrhage, which is the second most common cause of stroke after ischemia. And then the hypertension is the #1 risk factor to intraparenchymal hemorrhage. So this type of hemorrhage is associated with microaneurysms of the perforating arteries, also known as Charcot-Bouchard aneurysms. So let me show you an example. So here we have the middle cerebral artery, and then the perforating arteries are being distributed into the brain. So up there, right here, we have a Charcot-Bouchard aneurysm, and if this aneurysm rupture, it will cause an intracerebral bleeding. So here is a CT scan of an intracerebral bleed. So here you can see that there is blood inside the brain, and the darker area around it is the edema. Now, the most common sites of the brain that can undergo intraparenchymal hemorrhage is the basal ganglia, internal capsule, thalamus, pons, as well as the cerebellum. Now, if the hemorrhage is inside the subthalamic nucleus of the basal ganglia, so if it's in the subthalamic nucleus of the basal ganglia, it will cause hemiballismus, which presents with unilateral flailing of the extremities. So again, basal ganglia is one of the most common sites of intraparenchymal hemorrhage, and so if the subthalamic nucleus is affected, it will cause hemiballismus, which presents with unilateral flailing of the extremities. The next condition is subarachnoid hemorrhage, which is from the rupture of berry aneurysms that are found inside circle of Willis. Now here I have a memory aid that will make it easy to understand subarachnoid hemorrhage. So subarachnoid, BA, is associated with berry aneurysm. And so berry aneurysms are usually seen in patients with Marfan's disease, Ehlers-Danlos, as well as autosomal dominant polycystic kidney disease. The other characteristic of this type of hemorrhage is that patients complain of the worst headaches of their life. So another memory aid here is again BA. Bad ass headache is associated with subarachnoid hemorrhage. And then due to the breakdown of the blood products that is now in the subarachnoid space, patients can develop aseptic meningitis. So they would have neck stiffness similar to meningitis. Now, if you obtain a lumbar puncture, let me ask you a question. Once you obtain a lumbar puncture, where do you draw this cerebrospinal fluid from? So for lumbar puncture, you will have to draw the cerebrospinal fluid from the subarachnoid space. So in patients with subarachnoid hemorrhage, since there is no bleeding in the subarachnoid space, once you draw the CSF from subarachnoid space, there would be blood inside the CSF. Or alternatively, if the hemoglobin degradation products are there, it would be yellow color, which causes xanthochromia spinal tap. So let me show you some visual examples. So here is an example of a berry aneurysm in the circle of Willis, and if this berry aneurysm breaks, then it will release the blood in the subarachnoid space. So here you can see how the blood has covered all the subarachnoid space. And then the breakdown product of this blood can cause aseptic meningitis. So these patients can present with the neck stiffness. Here is another example that shows you we have pia, arachnoid, and dura, and then the berry aneurysm is in between pia and arachnoid. So this is the subarachnoid space. If it breaks, it will release blood in the subarachnoid space. And on the CT scan, this is the kind of appearance that you will see on the imaging for the subarachnoid hemorrhage. Now, once you want to obtain a spinal tap, what you will have to do is that you will have to cross the skin, the muscles, past the epidural space, and then finally you will reach the subarachnoid space, and then from there on draw the fluids. And now, since there has been bleeding in the subarachnoid space, the spinal tap could be either bloody or it could be yellow from the breakdown products of hemoglobin. Now let me ask you a question. Here it says that L3 and L4, so it gives away the answer to my questions. But what are the spinal levels through which you can obtain a spinal tap? So the spinal cord ends at the L2 level. And so you can obtain spinal tap from lower levels. So you can obtain it from L3, L4, or L4, L5. But then the other question is that how can you find these levels like L3, L4, and L4, L5? Are you going to count from the top all the way to the bottom? So how are you going to find out where is the lumbar number 3 and lumbar vertebra number 4 and 5? And the answer is that you will use the iliac crest as your landmark. So the iliac crest is at the level of L4. So if you go one level up, it's between L3 and L4, and if you go one level down, then it's between L4 and L5. Alright, now that we are done with the discussion of both hemorrhagic strokes as well as hematoma, let me quickly review the important findings. So with the epidural hematoma, it has a shape of ellipse or a lens-shaped, and then these patients present with lucid interval. So they would go unconscious, regain consciousness, but then they would go unconscious again because of the increased size of the hematoma. This type of bleeding is from the trauma to the temporal bone, which causes rupture of a middle meningeal artery. And then as we discussed, there is a lens-shaped appearance. Cranial nerve 3 palsy may happen, but this condition is very rare. And then patients present with a lucid interval. Another feature of this type of hemorrhage is that it does not cross the suture line. And the reason is that dura is tightly bound to the skull, and so therefore the bleeding cannot pass the suture line. Next, we have the subdural hematoma, which is more commonly seen in elderly patients since they have the brain atrophy, and so it will provide more space for the bridging veins to move around and get ruptured. So falls in elderly patients as well as like shaken baby syndrome is associated with subdural hematoma due to the rupture of the bridging veins. And then the appearance of this type of blood is a crescent-shaped hemorrhage. Now the memory aid that I have for you is subway under the bridge. So subdural hematoma is due to the rupture of the bridging veins. Next, we have the subarachnoid hemorrhage, which presents with a badass headache, so the worst headache of your life, as well as a berry aneurysm. So rupture of berry aneurysms, which are seen in Marfan's disease, Ehlers-Danlos, as well as autosomal dominant polycystic kidney disease, can lead to subarachnoid hemorrhage. And then again, described as worst headache of life, it can cause neck stiffness, and this is due to the breakdown product of the blood that is inside the subarachnoid space, and it will cause an aseptic meningitis. And then lumbar puncture may reveal blood or xanthochromic spinal tap from the breakdown product of the blood that is released in the subarachnoid space. And then finally, we have the intraparenchymal, also known as intracerebral hemorrhage, which is commonly caused by the hypertension, and it usually occurs in the basal ganglia and the internal capsule. And so it's from the rupture of Charcot-Bouchard aneurysms that are from the perforating arteries. So let me show you again. So here we had the Charcot-Bouchard aneurysm from the perforating arteries. And then if the subthalamic nucleus of the basal ganglia is affected, these patients present with the hemiballismus, where there would be unilateral flailing of the extremities. Now, as for the management of hemorrhagic stroke or hematoma, what you will have to do is that first check ABC, so airway, breathing, and circulation, check vital signs, and if possible obtain some history from people who are around or maybe even from the patient. Then you will have to order a non-contrast head CT. So it's important that you order non-contrast. You shouldn't order it with contrast. So if you add contrast to the CT scan, then the contrast dye can interfere with the visualization of the blood. So in order to differentiate between ischemic stroke and hemorrhagic stroke, it's important that you order non-contrast head CT. And then given that the patient could have had a stroke, you should consider the risk of aspiration as well as the elevated intracranial pressure. And so both of these conditions can be helped by elevating the head of the bed to 30 degrees. And then you could also consider thrombolytics in patients that have ischemic stroke. So after you do a CT scan, if you rule out hemorrhagic stroke and you are in the window of 3 to 4.5 hours since the start of symptoms, then you can consider providing these patients with thrombolytics. And so the reason I say 3 to 4.5 hours is that it all depends on a center. If you are in a specialized center, you can extend the window up to 4.5 hours. So the window of the time you can give thrombolytics for ischemic stroke is 3 to 4.5 hours. In addition, you should also provide aspirin to these patients. But in any case, notice that I haven't spoken about ischemic stroke in this video. So any of the conditions that I've listed here, hemorrhagic stroke or hematoma, it's contraindicated to provide any thrombolytics. And so once you order a non-contrast CT, that was the time that you would have determined whether it's ischemic stroke or whether it's a hemorrhage. Now, as for the blood pressure, it's recommended to keep the blood pressure less than 220 over 120 millimeter mercury if thrombolytics are not given. Once you give thrombolytics for the cases of ischemic stroke, it increases the risk of bleeding. So at that point, blood pressure goal would be less than 185 over 110. So that is for the general management. But once you know exactly what's going on with the patient, then you can be more specific with your treatment. So if the patient has epidural hematoma, which is determined with your non-contrast CT scan, then you will have to do an urgent surgical evacuation. On the other hand, if there is subdural hematoma, then you can do supportive care, and then depending on how severe and how big is the size of the hematoma, you could again consider surgical evacuation. For subarachnoid hemorrhage, you will have to clip or coil berry aneurysm, and then you should also provide these patients with nimodipine, which is a calcium channel blocker that will prevent the vasospasm. So by preventing vasospasm, you will prevent the rebleeding in patients with subarachnoid hemorrhage. And then finally, with the intraparenchymal hemorrhage, you should control the hypertension as well as the intracranial pressure, which is done by raising the head of the bed, hyperventilating these patients, and providing mannitol. So mannitol is a diuretic which will of course decrease the pressure inside the brain. Raising the head would help drain the head from all the blood that is inside the brain. So these two mechanisms are obvious that would decrease the intracranial pressure. But here I have a question for you. How does hyperventilation decrease intracranial pressure? And the answer is that hyperventilation will decrease the amount of CO2 inside the brain, as a consequence of which there would be vasoconstriction. So now less blood can flow inside the brain, as a consequence of which the pressure inside the brain will drop. And then finally, surgical evacuation would be a possible option for intraparenchymal hemorrhage. And that concludes our discussion of hemorrhagic stroke as well as subdural and epidural hematoma.